I was resident in pediatrics, in the Department of Pediatrics, and I was making my first on-call duties in the night. I was always very afraid of taking decisions to give antibiotics or to put one medicament or another. There were by which I felt actually very comfortable to give it. It was a volume therapy. And it was also an orgasm to take a decision by myself without having to ask somebody. It's okay to put antibiotics because the baby has something. So volume therapy, we have the impression this is something probably doesn't help, but it doesn't harm. And I think it has changed too much on time, at least when I see our young residents. Everybody is ordering volume therapy. Only the cleaning personnel is not ordering volume therapy. But everybody feels comfortable with that. And when you ask the people, do you have the impression that you help with that? They say, very often they say no. Nothing changed. So what I want to give you this morning with this lecture, I want to make you unsure about what this therapy is. I think all people attending these seminars like to suffer because you go out with more questions than when you came in. But I think it's important to be very critical about things we are doing every day. So some general considerations. You see, this is a very common therapy. Approximately 40% of ventilated preterm infants with less than 30 weeks gestation have an arterial hypotension in the first 24 hours. We can discuss what an arterial hypotension is. But with the different definitions we have, many of these babies at least have a low blood pressure for our definition. And depending on the source you look at, you find a huge difference in the incidence of the administration of volume expanders. Between 16 and 52, maybe half of those babies in some hospitals get some volume. And when you ask these people, why did you apply some volume, they say, because we wanted to treat a possible hypovolemia. We have the impression that the baby has hypovolemia. But many of them, they don't even mention this word. They give just volume to improve the cardiovascular condition of the baby. And you see that many of these small preterm infants also receive catecholamines in some centers. Also, there's a huge difference between one hospital and another, but in many hospitals these babies get catecholamines because the blood pressure is low. And in some data you find also that 50% of preterm infants with less than 1,500 grams receive volume even without hypotension. When I was a resident in neonatology at the beginning, I would say 80% of all small preterm infants got volume. And the reason for that was that the baby didn't look well. That was the reason for that. The baby was pale, or the refilling time was not completely normal, etc. And if you see more new data, not completely new, but more new data. This is a study in Canada looking at consensus in the diagnosis and therapy of arterial hypotension in preterm infants. They sent a questionnaire with different questions, and they got this number of questionnaires back with information. And you see probably what we all do. We give approximately 10 milliliters per kilo, 20, and probably not more than 20, 30 milliliters probably is the amount. And you see these are the doses of catecholamines, which are very common therapy, especially if you see that the majority of patients with hypotension get the first option, first therapeutic option, volume, almost all of them. Saline, fortunately, is the most common used solution to expand the volume. But you see that the majority of patients need a catecholamine thereafter. And if it's the distribution of these patients according to the therapy, you see this is volume, and then dopamine, and then dobutamine. Volume, dopamine, epinephrine. Volume, dopamine, steroids. But so the majority, the big majority of those patients do not get healthy just with volume application. And if you say these babies have a hypovolemia, this is the reason for the low blood pressure. You expect that if you give volume, you will solve the problem. but you do not expect to give catecholamines thereafter. So what are the effects of giving volume? You know that there are maybe 4 main determinants of the cardiac output. One is the preload, the other one is the contractility, the heart rate, and the afterload. And of course, if you give volume, you expect to increase the preload. You remember the Frank-Starling relationship. If you distend the myocard more, you will have more force or contraction. This is the main effect of giving volume, to increase the preload. And if you increase the preload, you will have a rise in the stroke volume. And if this is the cause for hypertension, you expect that the blood pressure will go up with the therapy. And of course, the cardiac output as well. So what are the main indications to give volume as a bolus? Arterial hypertension is probably the most important indication, but it's not the only one. Some people, as I said, the bad peripheral perfusion is an indication. Some people give volume when the babies have metabolic acidosis. And this is very concerning because you probably know all those babies with less than 1,000 grams, they develop almost all of them a certain amount of metabolic acidosis. So you should treat, if this is correct, you should treat all these babies with volume every day. And there are other indications that routing, in the old days, there were people who thought that it is probably normal to give volume as a routine therapy for small preterm infants. And even in the resuscitation guidelines, if you read the baby is not responding to the resuscitation measures, hypovolemia should be considered, and maybe you have to treat the babies with volume. So this is the only medicament which is mentioned besides epinephrine in the resuscitation guidelines, as you know. So let's take the blood pressure first of all, because I said the most important indication for volume therapy is hypotension. And this is not very unproblematic. The first question you will ask is, what is the normal values? And you know the normal values are probably completely different for a small preterm infant with 24 weeks than for a preterm infant with 32 weeks. This is the first point. The second is that many of these patients, when you measure the blood pressure, many of them are not completely healthy. You have to define what is a normal healthy preterm with 24 weeks. It's also difficult to define. The second point, which is a big problem, is the method of measurement, because you probably know that it's not the same, you don't get the same values if you measure the blood pressure in a peripheral artery, that if you're measuring it through an umbilical catheter in the aorta. The values are a little bit different. And the difference is much more if you are measuring the values not invasively. And if you see in the literature, the methods of measurements are completely different from one patient to another, even in the same study. And to complicate the whole thing even more, we now know that there's a very poor correlation between the blood pressure alone and the cardiac output and even the cerebral blood flow in small preterm infants. We used to say that the auto-regulation of the perfusion in the brain doesn't function when the baby is very preterm. But this is probably not true on the whole. It doesn't function in the same level as a mature infant, but some baby shows a certain degree of auto-regulation. And this is a paper from a group in Australia, you maybe know, Martin Krukov and Nick Evans. And what they do is to measure the flow in the vena cava superior, and they take this parameter as for the cardiac output. And the reason for that is that we know that the blood coming through the vena cava superior downwards to the heart, 80% of this blood is coming from the brain, and approximately 20% is coming from the head and the face of the baby. And they say, if you can measure the flow coming from the brain, this is a good parameter to estimate the cardiac output, especially going through the brain, which is probably the most important organ. Not for everybody, but so, and why they say it's a normal value is approximately 40 milliliters per kilo per minute. So this is a normal range. Here is a low cardiac output, and here is a high cardiac output. And if you compare it with 30 millimeters of mercury, which was based on one paper, was the definition of hypotension for many, many years. You can see that, in fact, there are some babies that having a blood pressure of less than 30 millimeters mercury, they have a low cardiac output. But you see lots of babies with a low cardiac output, defined as 30 millimeters of mercury, which have a normal and even high cardiac output. And what is more concerning is this quadrant here, that many babies, not many, but few of them, have a normal blood pressure, and they still have a low cardiac output. And this slide shows you how difficult is it to estimate the cardiovascular function of a baby with only one parameter. And that's exactly what many people are doing all days in the neonatal care unit. They look at the blood pressure, if it's low, the baby is bad, if it's normal, the baby is doing well. So it's much more complicated than that. Probably the most important question we should ask is, what is the reason for arterial hypotension? What is the reason for a low blood pressure in those babies? And you probably know, you take this slide out, please. Okay, you have the microphone. Sorry. You probably learned from physiology, if I ask you, what is the determinant of the blood pressure? You will say this is a relationship between the flow and the peripheral vascular resistance. Everybody answers this. But this is not always true, or not completely true. If you have a continuous pump, like this one, it's pumping continuously blood through this tube. And this tube is not elastic. It's a stiff tube. This definition will be 100% correct. The pressure in the system will depend only on the flow you have and on the resistance you put for this system. But the cardiovascular system functions in a very different way. You put also this slide out, please, because I don't know the reference. That's a problem. So you have an intermittent pump. So you put, it's like this pump here represented like the heart. You pump in the systole some blood out of the heart. And the tubes are elastic. Your arteries are elastic. So when you have a systole, you put a certain amount of blood into the arteries, and you distend the arteries a little bit more than before. And then you have the closure of this valve, but you still have flow. And in this case, the flow through the capillaries is due to the compression of the blood through the vessels. And this is something many people forget, that actually is not the heart responsible for the flow through the capillaries, it's the vascular system itself. You don't need the heart. The heart is only important to create a gradient, to maintain this system of arteries filled with blood. If you take into account this, you can say that the only or the most important parameter to determine how high or low the blood pressure is going to be is the amount of blood you have in a certain instant in your arterial system. If the artery is empty, whatever the reason it is, and you have more blood on the venous side than before, the blood pressure will be low. And of course, how much blood you have in the arteries depends on a balance between the amount of blood putting out from the heart and the blood coming out of the arterial system. You understand? For example, if you open the capillaries, at that moment when you open the capillaries, the blood flow will increase through the capillaries because the resistance is now low. But the amount of blood coming from the heart is the same. So you will empty a little bit your arterial system, and you will reach another point of equilibrium when the same amount of blood coming out of the heart is exactly the same amount as coming out. This point of equilibrium is always reached as long as you live. If you're dead, there's no point of equilibrium. But why I want you to understand it is that the main value to determine the blood pressure is how filled the arteries are, the arterial system is. Okay? If you take this pathophysiologic concept to a question, what do these babies have an arterial hypotension? And you know that the pressure is dependent on the filling of the arterial system. Then there are three possibilities. Maybe you have a hypovolemia, so there's not enough volume in the whole system. And in this case, if you give volume, this would be the correct therapy. You will solve the problem. But maybe the pump is not functioning. So if the pump is not putting a normal amount of blood out of the heart, the blood coming out of the arterial system will be more, and the arteries will empty a little bit. Okay? So in this case, if you have a pump which has problems to pump, it's not functioning well, and you're increasing the distension, and usually these pumps, these hearts having a problem, are already distended at the end of the Frank-Starling curve, and you give more volume, this therapy probably not be very wise. It will be probably contraindicated. If you see a patient with a chronic heart failure, you never give volume, you give diuretics. Okay? So in the third possibility is that they have a problem with the vascular resistance. And in this case, it's not sure if you are improving really by giving volume. Maybe you have to give lots of volume. Maybe you will not see an increase in the pressure, but only in the cardiac output. So it's not clear what the response would be to volume therapy if the problem is here. Okay? So let's look at these three possibilities and try to find out what these babies really have. And the first thing, and this is an argument of many people to give volume, is that these babies have hypovolemia. And I want to try to show you that it's not true. So there are a few old studies showing very interesting data. This is a study showing the correlation between blood pressure and blood volume. 61 preterm infants with and without hypotension, and they made measurements of blood volume with a dilution technique. And these are the results. There was no difference. There were no differences in blood volume in the two groups. Babies with hypotension and with normal blood pressure had exactly the same blood volume. More than 50% of infants with hypotension, that was the definition, did not respond to albumin administration. This is something we see all the time in our units. Everybody gets volume, but nobody improves, actually. And what's really different or concerning and very consistent in the literature is that any time you give volume, you produce a problem in the respiratory situation of the baby. And this is probably because you cause some certain amount of lung edema. This is another old study, randomized control study, showing the effect of dopamine or plasma on the blood pressure. So they took 39 small infants with arterial hypotension and were randomized to get plasma or to get dopamine. And you see 45% of the patients in the group 1, so with plasma, responded to the therapy, less than half of them, whereas 90% of the babies getting dopamine responded to the drug, improving their blood pressure. So the question is, if hypovolemia is the real cause, you expect exactly the opposite, because you cannot improve the condition of a patient with hypovolemia just by giving dopamine. So this is another indirect evidence that probably hypovolemia is not the main problem in these patients. This is a more recent study showing the hemodynamic effects of volume expansion and dopamine in preterm infants. Also randomized controlled trial, small study. One group of babies received dopamine with 5 micrograms per kilo per minute, and the other volume with albumin 20%, which is actually a very high concentration. We usually don't give 20%, only 5%. So this has a huge effect of volume, pulling some volume from the interstitial space. And these are the outcomes. They examined the left ventricular output in echo and the cerebral blood flow by xenon clearance before and 2 hours after the treatment. And these are the results. You see this is the control group. This is the group with dopamine, the group with volume. And you see if you take into account the blood pressure, dopamine again was very effective in improving the blood pressure, much more effective than the volume therapy. So you cannot improve actually in many, many babies the blood pressure by giving volume. And this makes very improbable that the real cause for hypotension is hypovolemia. If you take a look to the left ventricular output, you see that both therapies increased the amount, but volume was more effective in improving the cardiac output, showing the bad correlation between blood pressure and cardiac output again. And what's really interesting is that the cerebral blood flow was at least not significantly different, with a tendency also for volume to improve more than with dopamine. Another interesting study, 12 preterm infants with suspicion of hypovolemia. They get 6 milliliters per kilo, may sound a little amount of volume, but again 20% albumin, so it's not so little. And they show that after giving this amount of volume, the blood volume increased by 15%. So it was effective in increasing the volume, of course. What was really interesting is that after 3 hours, the volume, the intravascular volume, was exactly the same. So it means that the volume you apply in many cases disappears from the intravascular system very fast. And probably the more immature the baby is, the faster this process takes place. And the question is, if the volume is not in the intravascular system, where is it? And probably one part of the answer is in the lung. And if the baby is being ventilated, you will probably worsen the condition of the baby without improving the blood pressure, and with the question if you are doing really something good for the baby in terms of cardiac output. So the diagnosis of hypovolemia should be absolute or relative. Relative hypovolemia means that the vascular system is so big that a normal amount of fluid is not filling it up, like in the case of a septic shock. This is a classical example. But we are usually talking about absolute hypovolemia. And the most common causes for hypovolemia, for real hypovolemia, is the bleeding from the placenta, the feto-maternal transfusion, the feto-placental transfusion. This concept is probably not well known for everybody. That means that when you have a compression of the cord, the first vessels that collapse are the veins, of course. So the baby is still putting blood to the placenta, but this blood is not coming back. So this is so-called feto-placental transfusion caused by compression of the cord. And of course, the feto-fetal transfusion. And you see the whole bulk of these diseases, you get information from the clinical history from the gynecologists. And the clinical picture is not specific. The babies are pale. They may have a hypotension, may not. They usually, if they are term babies, have a tachycardia or a bradycardia in the very, very late phase of hypovolemia. In preterm infants, we actually don't know. There are not good data to say that all babies, preterm babies with hypovolemia, get tachycardic. We actually don't know. And we used to say that the refill time is prolonged. And this is also a big problem to define that. So all symptoms are not specific. The heart rate, as I said, there are not, especially in preterm infants, not enough data. And this refill time has a significant positive predictive value only if it is more than 5 or 6 seconds, which is a very, very long time. Yeah? And the results, when you revise the literature, is very interesting to see. You know, we take into account usually 3 seconds as a normal value. And if you look, where is this number? Where's the origin of this number? It's crazy, but this is something that probably a nurse said. Because somebody made an experiment and he said, in babies who are sick, this time is prolonged. And then the nurse was asked, how prolonged? And she said, approximately 3 seconds. You laugh, but this is real. You can read it in the papers. So it depends on the place you measure it. It's not the same if you measure it in the heel of the baby or in the sternum or in the forehead. and it depends on how long you press. If you press for 2 seconds, you get a different value. If you press for 4 seconds, it depends on the temperature of the room. So it's a very, very problematic parameter to evaluate the cardiovascular system of a baby. Blood pressure, we already said, there is no correlation with the cardiac output. It's a very late sign of hypovolemia. You can make experiments with animals. You cut a vein and you let the animal to lose blood, and you see that the blood pressure remains constant for a long period of time. And just at the end of hypovolemia, the blood pressure is going down. This is due to the several mechanisms we have to compensate the fall of the blood pressure, especially vasoconstriction. So if you say that the baby is hypotonic, has arterial hypotension because of hypovolemia, the baby must be dying, actually, at the end of the curve. This is another study from the same group in Australia, in 128 infants, trying to find out, especially the positive and the negative predictive value of a blood pressure less than 30, or what is more common used nowadays, to consider the blood pressure as the gestational age, the lower limit. If you have 24-weeker, 24 millimeters mercury would be the lower blood pressure limit. And you see, especially if you see the positive predictive value, that means how many of these babies with an altered exam will really be sick. You see they don't reach even 50%. Only if you take a refill time of more than 4 seconds, you increase to 55. And if you take two parameters together, blood pressure less than 30 and capillary refill time more than 3 seconds, then you increase the sensitivity to 78%. But the question is how the specificity is. So you see, these clinical data are not very reliable to establish the diagnosis of compromise in terms of cardiovascular system. If you want to diagnose hypovolemia, probably the most important thing is to take into account the hematocrit or hemoglobin, because you usually expect a fall. Of course, not immediate fall in the concentration of hemoglobin, but in the next hours, there's transport of fluid from the interstitial space to the intravascular system, and you should see a fall in the concentration of hemoglobin. If you don't see any change, hypovolemia or bleeding is very, very improbable. And the distribution of fluid is relatively fast, especially in preterm infants. The intravenous pressure is a well-established parameter. It's not reliable in the presence of intracardiac shunts, which is always the case in small preterm infants with open ductus and open foramen ovale. And it's difficult to measure because you need a thick catheter. This is a gold standard in patients in the pediatric intensive care unit, where you can measure lots of things, but not in preterm infants. And some people try to evaluate the amount of volume depending on the diastolic volume of the echo. But there are great variability of normal values, influenced by several factors, also intracardiac shunts. So it's very difficult also to evaluate with other methods like echocardiography or measurements of pressure through a catheter. So this was hypovolemia. The other two possibilities were a bad pump function or the low vascular resistance. Let's look at that. And this is also very interesting. So sick preterm infants with hypotension or acidosis often have a myocardial dysfunction. You see, when we started making echocardiography to all babies with asphyxia, we suddenly realized that these babies, many of them, they have a bad pump function. And many of babies which are only preterm infants, they also have a myocardial dysfunction. Many preterm infants with hypotension present a low vascular resistance and a normal stroke volume. This has also been shown. Preterm infants with hypotension often present a transient suprarenal insufficiency. Many of these babies are being treated with hydrocortisone nowadays. And preterm infants with a low flow in the vena cava superior show a low contractility and a high vascular resistance, also from the same group. So you see there's evidence for both things. that the pump is sometimes not functioning adequately. And then some babies have also a problem to maintain the vascular resistance. So it's not hypovolemia, it's the other way around. This is a study in preterm and full-term infants in the first 6 hours of life. And what you see here, it's a parameter of the contractility. This is, let's say that way, this is the afterload. When you increase the afterload, you expect a decrease in the velocity of contraction. This is a physiologic principle. If you increase the afterload, it's more difficult to ventricle. The ventricle needs more time to contract. If you open the periphery, the contraction will be very fast. So the velocity of contraction normally decreases if you increase the afterload. So the normal, this is a normal line, is always going down, because if you increase the afterload, you will have low velocity or less velocity of contraction. But what you see here is that there's a difference in the orientation of these curves, showing that those babies who are preterm, they decrease their velocity more fast if you increase the afterload. That means that these babies have a bad contractility in comparison to this group of babies. This is normal reaction of both, but the curve is very steep in the case of preterm infants in the first 6 hours of life. If you make the same experiment after 5 days of life, you don't see any significant difference, showing that this is a transient problem of the preterm infant dealing with a high afterload. Okay? And the baby compensates the problem after 5 days, whatever the mechanisms are. And this is another study dividing the patients in 2 groups, babies with a normal flow in the superior vena cava and babies with a low flow, so with a normal cardiac output and a low cardiac output. And exactly the same, this is the stress in the left ventricular wall, that means the afterload, let's say that way, and this is the velocity of the contraction. So you expect a fall in the velocity of contraction. This is a normal thing. But if you compare those babies with a normal cardiac output and a low cardiac output, you can very clearly see that these babies with a low flow in the vena cava superior, they have a problem with their contractility, showing that these preterm infants, they have actually a problem with the pump function of the heart. And on the other hand, if you see, this is again the cardiac output, this superior vena cava flow, and this is the vascular resistance. And they found that in those babies with low levels of cardiac output, the vascular resistance was increasing. This is a mechanism to compensate the blood pressure, of course. The pump is not functioning adequately, and you try to close the periphery to maintain the blood in the arterial system, to increase the blood pressure. Okay? So resuming these, we can say that probably the clamping of the placenta, and you should know that the placenta has a very wide vessels. It's a low resistance system. When you clamp the placenta, you increase the vascular resistance for the left ventricle immediately. And on the other hand, if you have lung disease, you will have a certain amount of pulmonary hypertension. And many babies not presenting the typical signs of pulmonary hypertension, if you make an echo, you see that the right ventricle is dilated, that the septum is a little bit flattened, and you probably see that the shunt through the ductus is in both directions. These are very mild signs, but demonstrating that many babies having a lung problem also have a certain amount of pulmonary hypertension. So it is on the other side, on the right side of the heart, also an increase in the vascular resistance. And this, for an immature heart, represents a very high afterload, and the babies had a bad pump function. This is probably the cause why these small preterm infants have hypotension initially. And the question is, if the baby is able to produce enough amounts of cortisol and catecholamines, maybe the blood pressure will be not present. If the baby is able to produce vasoconstriction, the blood pressure will be normal. If the baby has not enough cortisol,
maybe you see hypotension. That would explain what some babies with a normal blood pressure still have a low cardiac output. So you have to forget the blood pressure as a good parameter evaluating the cardiovascular system of the baby. Unfortunately, because it's very easy to measure, but very unreliable. So what about the other indications of volume therapy? Bolus administration during resuscitation, this is also a common procedure. The indication is usually paleness or the failure to respond to resuscitation measures. But paleness is very often present only in babies with acidosis, respiratory acidosis or metabolic acidosis. Patients with perinatal asphyxia often present a cardiogenic heart failure, which means that if you give volume, you probably worsen the condition of these babies. And there is a very, very solid evidence in animal experiments that asphyxia produces a placenta-fetal transfusion. So many animals with asphyxia, they have actually too much volume because the placenta produces a very severe vasoconstriction, pumping the blood out of the placenta through the baby. So these babies with asphyxia, and many of them are the babies which receive volume actually after birth, they already have enough volume in the intravascular system. The patient with a real hypovolemia usually respond very quickly to the volume administration. If your baby is with complications, I had a baby, for example, we tried to put a subclavian catheter, and the baby developed a hematothorax. And suddenly the baby was tachycardic and then going down very fast. Pale, the blood pressure was not possible to measure. And you give volume, we gave volume with the hand, and you could see immediately how the heart rate was increasing again. So the response is usually very, very fast if the hypovolemia is a real cause for the hypotension. You usually have an increase in the blood pressure and a decrease in the heart rate if the baby had a tachycardia before. This is an observational study of patients with cardiopulmonary resuscitation and the associated clinical events. All infants requiring chest compressions and or epinephrine in an urban county hospital for 2 years were included in this study. You see from this amount of newborn infants, only 39 were resuscitated. This is probably very consistent in the literature, 0.1% with compressions or epinephrine. And when they tried to find out what was the reason that these babies were so sick and needed resuscitation, you see severe acidosis was present in 25%. It was given as the cause for the bad condition of the patient. But very interesting, malposition of the endotracheal tube in 13% and ineffective ventilation support in 61%. If you take these both groups together, you see that the respiratory problems, the inefficacy of the ventilation is the main cause why babies get complete resuscitation with chest compression and epinephrine. And this is, of course, completely in accordance to the resuscitation measures, that they say the ventilation is the main point of the resuscitation in newborn infants. So it's not hypovolemia, it's the failing or the ineffective ventilation. In this study, they tried to characterize the use of volume expansion in babies with more than 34 weeks of gestation with cardiopulmonary resuscitation. It was a retrospective study between these years. And cardiopulmonary resuscitation was defined of like more than 1 minute ventilation and chest compressions. These are the results. This is the amount of babies. 23 infants had resuscitation. And 13 infants from this amount, so approximately half of them, received volume expansion. These are the data in the delivery room when the baby were born. And you see these are the babies without volume, and this is the babies getting some volume. And you see there were no differences in the gestational age, only parameters indicating asphyxia were bad in the group receiving volume. So the pH was lower epinephrine was given more commonly. So all those things showing that these babies were more sick than the other group. So we can say when the babies are sick, we have the tendency to give more volume. And these are the data of the same patients when they are admitted in the NICU. And you see the blood pressure, very interesting. The blood pressure was lower in the group with volume, but was still lower, although this group received volume before. There's a big difference, still 30 to 50. And you see the initial hematocrit. If you say, okay, these babies were hypovolemic, you will expect a certain degree of anemia in this group. And you see the hematocrit is 54 and 41. 41 is actually not bad for newborn infants. So there is also no evidence of that. And when they paid attention to the history of potential blood loss, they found only 5, and then after that they say only 3 babies met criteria for hypovolemia with hematocrit of less than 35% thereafter. So approximately 20% of those babies had probably hypovolemia as a result. So you see 80% of these babies have another problem, why they have to be resuscitated, probably more severe asphyxia, or probably the ventilation was a problem, not real hypovolemia. Volume as a therapy for metabolic acidosis. This is the indication with the least evidence. pH and base deficit have no correlation with lactate. Probably lactate would be the better measurement if you want to evaluate the metabolic acidosis. pH and base deficit do not correlate with organ perfusion. This is also a bad parameter. Very few studies, no effect, not recommended. So the main question is, for those people who say, okay, maybe it doesn't help, but it doesn't harm. Is there any risk to give volume? So volume overload in the case of myocardial dysfunction is not wise. We have seen patients with PPHN that get volume, and you can see immediately a decrease in the saturation because you increase the pressure on the right side of the heart and you increase the shunt from right to left. This is one example. There's a heart very compromised, especially the right side of the heart. If you give volume, you can worsen the condition of the patient. You can cause accumulation of protein in this interstitial space, especially if you give albumin. And you know that all this deteriorates the lung mechanics of the baby. So it will be more difficult to extubate. You will have more problems with the respiration. Risk of infection is probably very low nowadays, but if you use biologic product, it's also a possibility. And there has been associations, maybe very old studies, showing fast volume administration and intraventricular hemorrhage. And I wanted to show you just a few studies. It's a retrospective study over 2 years on volume administration in the first 48 hours and the outcome. This is the group of babies they included in the study, and they divided these babies in 2 groups, patients who died in the first 28 days, and they matched these babies with control cases that survived. 22 cases were compared with control cases. Patients who died received more than twice the amount of volume as patients that survived. 38, almost 40 milliliters per kilo in the first 2 days of life versus 18 milliliters per kilo. And patients who died have a lower temperature. There was also a significant difference between the patients. If they are very sick, probably they are also very cold. You see, these are the difference in the temperature, the difference in the volume, controls, and babies that died. And this is also very interesting. They divided patients in another way. They divided babies that got more than 30 milliliters per kilo, considering this is a high amount of fluid, and babies with less than 30 milliliters per kilo. And you see the differences. The birth weight was different. So babies getting more volume were smaller, had less weight. The maximum FiO2 was higher in the babies getting more volume, 80% oxygen, 60% oxygen. And all these, for example, these scores telling something about the severity of the disease shows that this group getting volume were babies, small babies, sick babies with more respiratory compromise. And if you take into account the blood pressure, which is always the argument, you see there was no difference between the two groups. And the question is, what's the reason for the physicians to give volume to this group of patients if it's not the blood pressure? The reason is that these babies were very sick. And we have the tendency to give volume, to do more if the baby is sicker. The question is, if these babies had already a very severe respiratory compromise, maybe we were contributing to the deterioration by giving volume in this group of patients. They asked, after this study, 37 pediatricians involved in the treatment of newborn infants. And you see 70% considered adequate to give 30 milliliters per kilo in the first 36 hours of life. 17% considered 60 milliliters per kilo as a normal amount or adequate. You know that probably the amount of volume, the whole volume of the baby is 80, so you almost perform a complete exchange transfusion. And only 6 out of 16 NICUs had written guidelines where they wrote that 20 milliliters per kilo was the maximum amount of volume you should give. So showing that many, many people are not sensibilized what they are doing with the volume therapy. And just to extend this a little bit, there's a Cochrane meta-analysis of restricted to liver administration of water. This is not volume administration, just water administration. But you see 5 randomized control trials. Restricted water intake decreases the risk of, interestingly, of NEC, patent ductus arteriosus botali. Increases the risk of dehydration, of course. Decreases the risk, it's a trend, not significant, but a trend to less BPD, less intracranial hemorrhage, less death. And we will hear something about transfusions, but there are now evidence that giving transfusions probably makes more severe subependymal bleeding, for example. I don't know if you are going to talk about that. But there's some evidence that transfusions probably are not very safe as we thought. If volume is necessary, what kind of solution? Colloids of crystalloids. There was a controversial association between albumin. You probably know, all of you, of this very discussed study. Human albumin 5% is 50 times more expensive than normal saline. And there are no consistent results in the adult literature. There are few studies in newborn infants showing no difference between albumin and saline. That's the reason why I recommend to give saline. There is no reason to give another one. This is a study showing that. This is a study, randomized control study from Hong Kong, using albumin 5% and saline. They didn't find any difference in the effectiveness of the volume challenge. But what's really interesting, that they showed more weight gain in the albumin group. This is consistent with the fact that when you give albumin, when you give proteins with the volume, these proteins go into the interstitial space and they cannot get back the same way. They have to be removed by the lymph system. So the treatment of edema is more prolonged if you give albumin than if you give just saline. So to end, blood pressure alone is an insufficient parameter to evaluate the cardiovascular status of a newborn infant. A real hypovolemia is rather rare in newborn infants with arterial hypotension. The clinical history gives almost always a clue if you have a hypovolemia. The administration of volume in the presence of deteriorated pump function and high vascular resistance can be dangerous, so you have to be very cautious about that. Large amounts of volume have been associated with increased morbidity and mortality. And if you suspect hypovolemia, use 10, maybe 20 milliliters per kilo of normal saline in 30 minutes. And if you don't see any response, look for other causes. You probably were wrong with your assumption of hypovolemia. Thank you.
Hello, everybody. Before you start the discussion, just two information. Yes, we have a great note when at the end of the discussion, but before the break, you have to fill in the form. Otherwise, Johnson Brunner will kill us. We all. So, so we have to before the break.
Do you have questions? No questions. Yes. Hydrocortisone. Yes. We use it. This is a very difficult question. You know, the classical indication was if the baby is not responding, or you cannot take the baby out of catecholamines, you give hydrocortisone. But I must confess that we have been very liberal in giving hydrocortisone, even before we give catecholamines, in a small dosage of 1 milligram per kilo. I don't know if this is correct. But there are some studies showing that dopamine and hydrocortisone are as effective, both drugs, in treating hypotension. And I'm not quite sure if we are always doing something good giving catecholamines. There are some studies showing that probably catecholamines, you know, there are no randomized controlled studies showing that giving catecholamines is good. We have the impression that we improve something. And I think that maybe hydrocortisone is, the increase in the blood pressure is lower. It's not so dangerous. You cannot make a big mistake, because I have seen mistakes in programming the pump with hypertensions of I don't know how much. So we have the impression that probably in the future, I don't know, this is just my opinion, but probably this medicament will be initiated earlier and not after catecholamines.
Most of us do it in the second step. We first give volume, then we start with and then dopamine.
Well, you know, we also give volume, especially when I'm not in charge, you know. But we used to say, give only 10 milliliters, and if there is no response, forget it. Forget the volume. Yeah. I think this is a good compromise. And then the second step would be, in my hospital, probably in many cases, to give hydrocortisone. That's correct. Yeah. But we have lots of patients with a blood pressure that you will probably consider low, and if the baby is moving and is looking well and is putting urine, we don't do anything. Yeah.
I think Dr. Seri writes very nice things about hydrocortisone in his last book. And he says when you are having severe and resistant hypotension, you should suspect if there is adrenal insufficiency. This is the case where you can give hydrocortisone. For as long as catecholamines, he says there is so many complications for the extreme premature babies, especially for the thyroid function, and for the long run. There's very, very bad complications using catecholamines in extreme premature babies.
It's probably true, yeah.
And the pituitary gland also.
I don't know your opinion.
And the white blood cells function, there's so many complications. Prolactin, about catecholamines.
Exactly.
Because I had the chance to do the same feature, that's what we did in Athens, about hypertension. And I had to read the book of Seri, the last one.
Okay.
And they give hydrocortisone if you want to give for hypertension. He advised to give hydrocortisone.
You know, some people say you have to take the serum levels of cortisone. We don't do that because it's so complicated. You need so much blood.
But we should take care, we are not should be giving Indoseed because there's high chance of intestinal perforation. Because most of
this is a problem, yes.
And this is a big problem.
This is a problem, yes. If you give hydrocortisone, you cannot use ibuprofen or indomethacin. You want to say something? No? Mario? You want to comment something? No.
We've limited volume for a long time, but the latest concept is other ductus is the big problem. Acting early, get on and treat the ductus. So increasingly, sorry?
That's because you've got Nick Evans in Sydney.
So increasingly, we've got a lot of cardiac performed ultrasound now, and increasingly, we're trying not to react to the blood pressure, but increasingly also we're saying we should be. Problem is moving from Indosid, where we were using it very early, partly still to think about preventing PVH, but it increased the use of Indosid within the first 6 hours. Now switched to Brufen, because we can no longer get Indosid. And Brufen not used within 6 hours like Indosid, but increasingly people are saying we should be trying to close the ductus early, even if it's transitory. So, you know, if the diastolic blood pressure is really low, treat the ductus. My preference is known volume, hydrocortisone but I tend to go to dopamine first still, because everyone is more happy with that.
Marius, your topic?
What about closing the ductus really early?
I thought Nick Evans was actually, I thought a trial was going on. I keep being told there really is a trial and there are going to be some objective data.
Yes.
That is correct.
That's right, but the rest of us aren't in the trial, so the problem is, you know, getting people to do the trials. Everybody else thinks they know, unfortunately, still, even though we know we don't know. And that's what's so elegantly being shown in this seminar.
You know, one of the studies that was done, it wasn't focused on this, but Laura Ment's trial with 1,206 babies,
Yes, Laura Ment's work.
randomized, they had lower duct
Yes.
presence, no difference in BPD,
No.
no difference in any of the, there's things that we talk about usually in conjunction with PA. Less IVH, no difference in neurodevelopmental outcomes. So,
But I for a long time thought if you had a new colleague, you ought to let him make one change to make him feel a member of the team. And we had a new colleague arrive from a centre where they were using prophylactic indomethacin, which very few centres in the UK have done. And I work in a hospital where we have a real preponderance of very immature, growth-restricted, difficult babies. And so we let him introduce the use of prophylactic Indocid, and we went with it for some time. We had no difference in our nasty IVH rates as far as we could see. And we have much more necrotizing enterocolitis than one would like. And at the end of the day, we said babies die from necrotizing enterocolitis, and they don't die from their ducts, and we stopped using it.
Yes, I agree.
Actually, that's the sequence we went through. But I don't know.
No, it's right.
But I absolutely.
And Brufen, and we've had perforation from Brufen. The more we use Brufen, the more we see perforation. And the babies then go to surgery for that. Huge sepsis, major lung disease after surgery. And you think, why did we need to close the ductus? Just because we can measure it. Again, the introduction of CCPU everywhere has been a real problem. You know, before we listened, we now know the ductus is open or it's closed. Did it matter? You know, now we measure it. Oh, it looks like it should be treated. I don't know what you're doing in your unit.
You know, we have a very low incidence of severe intraventricular hemorrhage. And that's the reason why we say, okay, we use prophylactic indomethacin only for those babies which have the highest risk in my hospital to develop bleeding, severe bleeding. And these are babies of less than 26 weeks without prenatal steroids. And we try to make this difference. But I think it's probably important to adapt the concepts to the situation in your hospital. And maybe the other thing is to regard the complications or the probable associations with duct on time. Because if you treat the baby to treat the ductus after 4 or 5 days, you are not preventing probably the intraventricular hemorrhage because it takes place in the first 3 days of life.
there's actually that very nice paper from Nick Evans showing that IVH occurs as you recover from the low cardiac output.
Yes.
So boluses and blood and all of those things probably aren't such a good thing.
There's also something very interesting. There are measurements. The person when I was working in Germany, my chief there, the Professor Stoppkuchen is his name. He's a cardiologist, pediatric cardiologist, and neonatologist. And he used to perform the echocardiography by himself. And he had I don't know, maybe 20 or 30 babies who got ligation. And he performed the echocardiography immediately before ligation and immediately thereafter. And many of these babies develop a severe cardiac failure after ligation. they can even die because of that. So it seems that the Frank-Starling relationship is a relative relationship, it's not an absolute relationship. So the ventricle gets used to a certain volume, and if this volume is less, which would be actually normal, is a hypovolemia for this baby. And I think this is another argument to try to avoid an operation, which is a sudden change in the whole physiology. If you give indomethacin or ibuprofen, it's a gradual change. And the duct doesn't close like in 2 minutes or 2 seconds. It takes several hours probably. Yeah.
But nobody ligates first, right? I mean, are people...
Everybody's
We used to.
Yeah.
We used to. We used to.
Which could be,
We used to do it too. We used
Yeah,
to
but
all
if you wait,
babies less than a kilo.
if you wait for 1 week, and you decide after 1 week to make a ligation, because after 1 week the probability that you could close the duct with indomethacin is very low, so we have this problem. You get the baby in heart insufficiency after ligation. It's very interesting. The blood pressure is very good.
Yes.
That's the problem.
That's the reason why the people didn't realize that.
That's right.
Yeah. Exactly.
Very interesting. Yeah.
Solve the problem.
Okay, thank you.